Even with proper placement of a supraglottic device, we can sometimes come across issues that we'll need to troubleshoot. Remember, this isn't a device where you just place it and ignore it. You need to constantly monitor this device and ensure that it's effective. When we come across issues is when we have ventilation that's adequate, but oxygenation that's inadequate. So the device is in the right place. We have chest rise and fall, and hopefully an end tidal CO2 within a normal range. But our patient isn't being oxygenated. So we need to ask ourselves, is the problem intrinsic to the patient, or is the problem intrinsic to the device? When we're thinking about problems that could be intrinsic to the patient, we want to assess our patient for tension pneumothorax, mucus plugging, or bronchospasm. One of the disadvantages of a supraglottic device is it doesn't have as high a leak pressure as you have with an ET tube. Patients with bronchospasm, such in the case of asthma or COPD, may have lower leak pressures, meaning these devices won't seal or provide as high pressure. So these patients are going to need to be treated for their bronchospasm. We're going to give them albuterol, Atrovent, maybe steroids, standard of care. It doesn't necessarily mean that we have to pull the supraglottic device, but we need to ensure adequate oxygenation through managing the patient. Some patients may experience mucus plugging where they need excessive suctioning. And in some cases, when we intubate a patient or place a supraglottic device on a patient who has a simple pneumothorax, we may convert it to a tension pneumothorax. So we may see signs of this later after the airway device is placed and need to needle decompress the chest. Let's move on to some things to think about that are intrinsic to the device. All too often we place these devices blindly. That's because we're not intubating the patient, we're not putting a laryngoscope down. So we can't see what's going on in the airway. There may be some sort of obstruction in the device. It may be something as simple as emesis, mucus, food, or any other foreign body. So if you're noting that you don't have any problems that are intrinsic to the patient, consider that your device could be obstructed. The second thing is herniation of the epiglottis into the outlet of the supraglottic device. This is easily fixed by withdrawing the supraglottic device and gently replacing it. This usually solves this problem. And of course, if there's food, emesis, or obstruction, you're going to need to pull a device, thoroughly suction, and you might need to inspect the airway with McGill forceps. The real take-home point here is that this device requires monitoring. Don't place the device and assume that it's working. Always maintain adequate oxygenation for your patient. And if the supraglottic device isn't providing this, you need to pull the device and try something else.